So chapter 23 is going to talk about gynecologic emergencies. So we're going to be talking about the female reproductive system. We'll have a totally separate chapter for obstetrics and talking about delivery of the babies. This is just simply talking about gynecologic conditions. So women are uniquely designed to conceive and give birth. That means that men can't do it. Sorry, guys. And so for that, they are susceptible to problems that do not occur in men. So looking at some anatomy and physiology, you have the external female genitalia, which has the vaginal opening to the outside world. And then you also have the labia, the majora, and the labia minora. And the clitoris. All of these are external structures. You also have some internal structures like the ovaries, which lie on each side of the lower abdomen, and they produce an ovum or an egg each month. Now, you are born with the amount of eggs or ovum that you are going to have, but one is released each month, generally one, sometimes more, and sometimes none. So we'll talk about some of those conditions. Fallopian tubes connect those ovaries down to the uterus, so that's how the egg or ovum travels. And the uterus is the muscular organ where a fetus would grow. The vagina is the outermost cavity of the woman's reproductive system, and we looked at those external structures. This is what the internal structures look like. So you can obviously, the uterus has that muscular look to it. The cervix, which is the neck of that, is actually your external opening to the vagina. The cervix is kind of leading into that. And so we would call that the neck of the uterus. Again, this just kind of breaks down how the fallopian tubes are connected to the ovaries and how that ovum travels. The uterus here looks very small. It can grow you up to 400 or 500 times its original size when it is impregnated and with a full-term baby. So ovulation and menstruation begin in puberty. Usually the onset of menstruation occurs between age 11 and 16. So you might see a test question that asks about the earliest time that's on average for puberty to start, and that is 11 years old. The onset of menstruation, that very first menstrual cycle, is called the menarche. Ovulation and menstruation will continue until the time of menopause, which usually occurs around age 50. So again, test question, at what time do you normally have menstruation? And that is between age 11 and 50. Each month, one ovum is released into the fallopian tube, and we call that time period ovulation. And so the process of fertilization begins in the vagina, where sperm is deposited from the male penis. They pass through the cervix into the uterus and up the fallopian tube. So actually, fertilization occurs inside of the fallopian tube. And so then that fertilized ovum or egg should travel down into the uterus to implant. And when it doesn't, if it implants in the fallopian tube, that's where we start talking about things like ectopic pregnancy. If fertilization does not occur within 14 days of ovulation, then the lining of the uterus begins to separate and menstruation occurs for roughly a week. And then you have a week of normal life, and then the cycle starts all over again. So looking at some causes of gynecologic emergencies, these are pretty varied, from sexually transmitted disease up to trauma. Looking at a few of those sexually transmitted diseases, we'll start with pelvic inflammatory disease, or PID. This is an infection of the upper organs of reproduction, the uterus, ovaries, and fallopian tubes. This occurs almost exclusively in sexually active women, which means it's nearly impossible to get it if you are not sexually active. It can result in increased risk of ectopic pregnancy or sterility if it's left untreated, and the most common sign is generalized lower abdominal pain. Looking at STDs as a whole, they can lead to more serious conditions like pelvic inflammatory disease. So usually that's where it stems from, is a lesser STD that goes untreated and leads to pelvic inflammatory disease. So chlamydia is the most common STD, and it's usually mild or absent, which means you can be a carrier of it and spread it without realizing it. It can spread to the rectum, and it can also progress into pelvic inflammatory disease. Bacterial vaginosis is the most common vaginal infection to afflict women. If it's left untreated, it can progress to premature birth or low birth weight if the patient is pregnant, and also pelvic inflammatory disease. This is fairly easy to treat with either oral or vaginal gels that can treat this like with antibiotics. Gonorrhea is when there is a growth of bacteria that rapidly multiplies in moist areas of the reproductive tract. And this affects both men and women. Severe infections can be present with cramping and abdominal pain, nausea, vomiting, and bleeding between periods, so it can spread systemically. Looking at vaginal bleeding, some possible causes can include abnormal menstruation, vaginal trauma, ectopic pregnancy, spontaneous abortions, cervical polyps, and cancer. And so some of the times when we would likely get an EMS call related to this would be like with the trauma or the ectopic pregnancy or spontaneous abortion. So the spontaneous abortion, the other term for that is simply just going to be miscarriage. And so those two terms can be interchangeable. So of course we want to make sure that the scene is safe. These can generally involve a large amount of blood, so we want to make sure we're using proper PPE. If there's any assault suspected, then we're going to want to contact law enforcement if they're not already on scene. The mechanism of injury may be easily understood from the dispatch information, like sexual assault, or you might not know what you're walking into. When you're getting your primary assessment and you're getting your general impression of the patient, you want to evaluate their airway, breathing, their pulse, skin color, temperature, and moisture. That can help identify blood loss. So we're looking for those signs of shock. Most gynecologic emergencies are not life-threatening. Usually from severe blood loss would be one of the times that it could be potentially life-threatening, but most of the time it won't be. It's simply just going to be uncomfortable or painful or require transport and assessment on our part. Looking at history taking, we want to investigate the chief complaint. Of course, these questions are going to be extremely personal, so ensure the patient's privacy and dignity are protected. If this is a patient who is a minor, you want to try to remove their parents from the scene as gracefully and dignified as you can by just having them maybe move over to another area, asking your partner to get some information from them while you discuss with the patient. If they're having abdominal pain, we want to ask about onset, duration, quality, radiation, again, using our OPQRST mnemonics. We're asking about other symptoms that could be related to this as far as nausea and vomiting. If they're having vaginal bleeding, we want to ask questions about the onset, the duration, and the quantity or number of sanitary pads or tampons that they've used and how long. So again, how long has this bleeding been happening, and then how many pads or tampons are they using? Generally within an hour. So if they're going through more than one an hour, that's definitely a really bad sign. Other associated signs like syncope or lightheadedness, so have they passed out or felt like they were going to pass out? And you can ask them to estimate the blood loss if it's visible, but a better way to do that is with the number of pads or tampons. Looking at a sample history, ask about the use of birth control pills or devices. We can ask about the last menstrual period and any known STDs. The last menstrual period is going to be really key in thinking about pregnancy. So asking the patient, is there a possibility that you could be pregnant, and when was your last menstrual cycle? Other things that are going to be really pertinent here, vital signs, like we said, blood pressure, pulse, skin color. Remember our orthostatic vital signs if the patient is changing position. So if they go from like laying down to sitting up or sitting to standing, if they have an increase by 20 beats per minute or more of their heart rate, or a drop in their systolic blood pressure by 10 points or more when having that positional change, those are positive orthostatic findings. Looking at the abdomen, we can look to see, is it distended? Is it tender? Are they having any visible bleeding? And is their mental status changing at all? We want to be very professional and limited with our physical exam. You only need to examine the genitalia when necessary. So if they've been assaulted and they have some type of obvious injury there, then yes, you can look at it. And again, when we're talking about obstetrics and baby delivery, yes, you'll need to look for crowning, but only look if you have to. Vaginal bleeding, we want to visualize it and ask about, again, quality and quantity. You can ask about the color. So is it bright? Is it dark? Is there clots? If so, how large are the clots? Those types of questions are pertinent. Asking about discharge as well. Have you had any abnormal discharge? What did it look like? Did it have an abnormal smell to it? Again, these questions can be rather uncomfortable, but need to be asked. Other things we want to consider: if the patient has passed out, also syncope, if they have a fever, nausea, and vomiting, all of these in combination with abdominal or pelvic pain and or vaginal bleeding can indicate really significant gynecologic emergencies. So we want to repeat this assessment as needed. Very few interventions that we can do here, but we do want to communicate all relevant information to the receiving hospital, including the possibility of pregnancy. So again, not much that we can do in means of care, keeping the patient comfortable, keeping their privacy maintained as much as possible. We can use sanitary pads or gauze to help control the bleeding and document the number of pads. Never place anything into the vagina, but we can place it on the outside to help soak up some of the blood. The external genitals have a very rich nerve supply, so this makes injuries there very painful. So if they do have any type of traumatic injury from an assault or whatnot, we want to treat any external lacerations with moist sterile compresses, but again, never packing anything into the vagina. Looking at pelvic inflammatory disease again, remember we said the primary complaint here is abdominal pain. The pre-hospital treatment is very limited and non-emergency transport is usually recommended. For sexual assault, unfortunately, sexual assault and rape are common. And so if you're treating a victim of a sexual assault, you're having many complex issues going on here. You might be the first person that the victim has come into contact with after the encounter. So be very professional, very kind, very sensitive. Usually if you can have someone of the same sex, so a female EMT or paramedic to talk with the patient, that's going to be the most helpful. Be aware of any drugs used to facilitate sexual assault or rape. So how is the patient acting? Do they seem like they're under the influence of something? Could they have potentially been roofied or had some type of other drug put into their system? If possible, give the patient the option of being treated by a female EMT. Like we said, that's not always the case, but if it is a male provider treating, make sure that you have a witness there. So family member, police officer, bystander, another EMT, 2 males, whatever it is, to do the best that we can to witness this. Your focus should be on the medical treatment of the patient as well as psychological care, and also preserving evidence and getting their history. I'm not going to read through all of these here. You can read through these in your book, but understanding that anytime that there's a possibility of sexual assault, you do want to make sure that you're documenting very thoroughly, because this could be called to court in a couple of years even. It's not usually a very fast process to go through that, unfortunately. So you want to make sure your documentation is very good. You don't want to have the patient urinate, defecate, shower, change their clothes, anything like that. That could interfere with evidence. If they do change clothes or for whatever reason, if they have torn underwear or something there on scene, try to transport those in a paper bag if at all possible to help preserve the evidence, and take those with you to be given over if they're getting ready to have a rape kit done at the hospital. So that's going to be it for gynecologic emergencies, and next week we will pick back up in what happens when you are getting ready to deliver a baby.